Greetings to all of you as we welcome you to joining this really auspicious event for us in the faculty. Inaugural lectures have a really special place in the life of a university, and particularly here where we've ended up having quite a gap in inaugural lecture celebrations due to the COVID pandemic. But I want to just make a couple of remarks regarding where we're locating these inaugural lectures in the faculty. And this is the first one that's being run by the faculty in what we regard as the rejuvenation of our process of acknowledging the scholars amongst us. Kamirodi Khais is the name that the original people of this area, the original Khoi people, called observatory, the place of the stars. So when we reflect, when I do anyway, on Kamirodi Khais, I'm really reminded about a place of the stars to which people come in order to cast light on our world, in much the same way as the stars in the sky would. And this is part of our new journey in rejuvenating the celebration of professors in our community. The inaugural lecture we see as becoming an important part of our faculty's life, because for us, the inaugural lecture represents the achievement of an individual, and the celebration of the lecture is then that intersection of their scholarship and their clinical practice with the community around us. So in many ways, in inaugural is meant to shift what is scholarly, take that scholarly enterprise and make it accessible to the people around us. Because all too often universities see themselves as above the people in many ways. And that's what we hope to change. So this evening, I want to greet the inaugural lecturer, Steve Roche, very warmly, and welcome to this event. Thank you for agreeing to deliver it on this occasion. But it's also a special time that we interact as a scholarly community. We interact with the family of those who work amongst us. So I want to welcome Steve's wife, Mareka, his son, Michael, and his brother, John. I think it's really important because we don't always acknowledge the sources of our work. And I think families are particularly a strong part of that. The importance of an inaugural lecture in and of itself really, for me, is located in that space. Chris Brink, who was the former VC at Stellenbosch, speaks about the fact that universities need to ask these two questions regularly of themselves. The first question that they should ask is, what are we good at? And then, what are we good for? And for me, that has to be the spirit of our university, and particularly our faculty, because we're a faculty where what we are good for is a crucial part of changing the course of our country. But Chris Brink goes on to say the first question is really about excellence. Who is expert at what? The second question is rather about purpose. How do we respond to the needs of and demands of our society? Both of these questions are important and legitimate. But he speaks about the idea that if we have a relentless focus on the first without a reflection on the second, then our excellence itself becomes tarnished a little bit. And I think that's a really important reflection as we begin to look at the scholarship in the space of clinical work particularly. This evening is important for us because it's really the first one of our new series of inaugural lectures, which we hope to now have monthly because we've got that many professors awaiting delivering their inaugural lecture. But it's really about showcasing those amongst us that the peers have found worthy of the title of professor. And so I want to welcome you again to this evening. I hope that you'll enjoy it. I particularly enjoy inaugural lectures, but I hope that you're going to enjoy this evening. And so I'm going to invite Professor Graham Fegan, to present, to introduce our speaker for this evening. I thought I'd planned all of the things I was supposed to say, but welcome, Graham.
Right, hi, good evening, everybody. Professor Green-Thompson, DVC Langer, Professor Roche. and everybody here. It's really an incredible honor to introduce tonight's inaugural lecturer, Steve, who not only is a greatly appreciated colleague, but also a long-standing friend, which I think applies to just about everybody in this room. I want to start by thanking everybody who's come in person and online to acknowledge Mareka, who's here with Michael, but also Stephanie, James, and Johnny, who are not here today, but I think may well be online. And Steve's parents, Nigel and Anne, who I believe are online in Harare. So they had 6 children. Steve is the second oldest. And we'll hear a few words from your older brother, Paul, just now. Just stand by. Johnny, Andrew, Matthew, and Anne-Marie, Steve's sister. So really thinking of all of you tonight, and all your nieces and the various grandchildren of the family, many of whom are logging on. So I'm not going to tell you much about Steve's early days. Professor Basil Fretos, who was at school with Steve, is going to propose the vote of thanks, and I think he'll have fun telling you a few secrets there. But suffice to say, I got hold of Paul, who is Steve's older brother, who's now a radiologist in Perth, who conceded that Steve was quite wild growing up, but he still managed to become head boy of his school. And famously had a horse riding accident. Sport was a very big part of his life. In fact, it's always been a big part of his life. And sadly, he fell off a horse and broke his arm just before the national school rugby trials, and missed out on getting into the school's team. But the interpretation is that's why he's become such a dedicated upper limb surgeon and somebody who relates very readily to elite sportsmen. He was also legendary for cramming, but I won't talk too much about his academic performance. Safe to say, Rory Harvey has pointed out to me, Steve's probably the only person in the history of UCT who passed 3rd year while still in 2nd year. But Steve can maybe tell you the story behind that. So our generation, kind of the usual sort of pattern was you finished medical school, did your internship, with Steve did it at Critiscare, and then you went off and did a few locums overseas and spent time in Canada. So Stephen Mareka went to Saskatchewan for 6 months and ended up being there for 3.5 years before being lured back here to do orthopedics, which Steve completed in 2000. And after qualifying, became what is called the Monday Trauma Clinic Consultant, which sounds to me like a bit of a hospital pass. Doesn't sound like the quietest job. And very quickly stepped into the role of running the shoulder and elbow clinic, and also sports injuries clinic, which has been a big part of his work. I'm not going to talk too much about that because I think that really is going to be the gist of what Steve is going to talk about this evening. But I think the one thing really to highlight is, for those who are not familiar with that hominem promotion process, individuals who get promoted get assessed in 4 different domains: teaching, research, leadership, and social responsiveness, or clinical work for clinicians. And you get scored between 1 and 10, and in those 4 domains, and it becomes exponentially more difficult to sort of get a higher score. And Steve is the first person, certainly, that I've had the honor of presenting for promotion, who came very close to getting a 10 for teaching, because his track record as a clinical teacher is absolutely extraordinary. And I think everybody who's had contact with Steve as a teacher and an academic will attest to that. On the national front, and Basil will speak to this, he's had an extraordinarily productive time. One of the most amazing things about Steve's CV, though, is he's managed to avoid becoming president of anything, which is really amazing. So you're much smarter than the rest of us. Probably one of the greatest indexes of your clinical skill is when your colleagues actually come and seek you out as their doctor. And Sean Longhurst, who many of you will know, has run the casualty at Victoria for many years, fell a horse while about to hike up Kilimanjaro, and got on a plane in Nairobi to actually come back and have Steve fix him. So just a couple of Steve's colleagues, Professor Rob Dunn, who really does deserve a huge amount of credit for the work that Steve has done and what he's been able to produce. Rob describes Steve as Mr. Shoulder and Elbow South Africa, and acknowledges the role that he played in establishing fellowships, which really have become an incredibly important part of subspecialty training in orthopedics in South Africa. It's really been a role model for people around the country. And the leadership Steve has shown in developing research with Sidesh Sivarasu in biomedical engineering, which I think we're going to hear an awful lot about. Professor Sitomba Makungu, who is Steve's colleague in orthopedics, wrote very movingly as a testimonial for Steve's promotion. And I just want to kind of read briefly from that. Sitomba wrote, "I want to comment on something intangible, something that cannot be scored, and that Steve is colossal in our department as a father figure to all of us. He's our moral barometer and ethical standard. It's well known in our department, if anybody has a moral or ethical dilemma in their clinical practice, they consult Steve for advice. His orthopedic knowledge is unbelievably vast, not limited to his own subspecialty. And even if he dozes off during a presentation, which I'm sure doesn't happen that often, when he wakes up, he always asks the most pertinent question. But nobody's allowed to doze off this evening. Steve has been and continues to be a role model and a mentor to me. He's acutely aware of the need for transformation and redress in the tertiary education sector in our country, and fully committed to it. He lives it and does not just pay lip service to it. His general outlook on life, combined with a well-developed and keen sense of injustice, makes him an irreplaceable colleague and mentor." And then Professor Alan Wang in Perth acknowledges the international leadership role that Steve has played, and describes him not only as a leading academic, but also a great mate and somebody that they always want to invite to their meetings. I couldn't let this introduction go without commenting from Sidesh and the orthopedics biomechanical lab. So Sidesh cryptically writes that Steve and I go back a long way to around about 2012, 2013. Neither of us can quite remember why or when we first met, but it happened, and here we are after almost a decade. Together with Steve's clinical expertise and our group's biomedical engineering expertise, we co-founded the UCT Orthopedic Biomechanics Lab in 2013. Steve is an inspirational figure and students love to work with him. He understands how to work and get work done with engineers, which is altogether a different skill. And Sidesh, I think this really says a lot for Sidesh's role as a mentor. Most of the tribute he sent me, he had given students an opportunity to comment. And Dr. Rupam Day, who's on the PhDs that Steve and Sidesh co-supervised, writes about Steve as having been one of the most influential people in my life. At his age, I'm not quite sure how to interpret that. If I'm half as hardworking and dedicated as Steve is, I will consider my life a success. I doubt he ever sleeps. I don't know if Mareka can comment on that. And then Alexandra Lancaster writes about Steve as a constant source of ideas and avenues to explore. Haptamo Yuman describes how Steve invited him to theatre to actually really understand what their work was all about. And Leanne Hayworth writes about Steve's enthusiasm and constant curiosity and approachability. But I want to end with the family. And Mareka did a great job last night helping me connect with your kids, Steve. So a couple of things to share. But just to share Mareka's perspective, that you've got a history of going big. You lose the plot sometimes with your Zimbabwean friends, but we all know you're a passionate and loyal friend, not only to your friends, but your colleagues and your family. So your closest admirers, your children, and your twin passions of sports and orthopedics, which kind of often go together, came through very strongly in your children's comments. So one of which was, Dad has missed his calling. He should have been a rugby ref or coach. Even the dogs leave the room when Dad watches rugby on TV. Dad loves supporting our rugby matches. Over the years, we've realized his support was actually a very smart business decision. He has a thriving orthopedic practice on the side of the field. He's a marketing genius. And then being the child of an orthopedic surgeon can be trying. We all remember the time when Michael broke his pelvis. After 4 more rugby matches and no longer being able to sit in his school desk because of the pain, he finally had an x-ray which confirmed a fracture. Great diagnosis, Steve. And then I want to end with Stephanie, who actually was in this faculty, and I'm not sure there's any student who got more class medals than Stephanie. and she's currently a junior doctor, I think, in KZN. And Stephanie writes, my favorite memories of Steve from Critis Gear, there are pros and cons to working in the same hospital as your dad. I once saw a doctor in grotties eating lunch in dirty scrubs, said very loudly to my friends, "That's so unhygienic," only to realize it was my dad. And then I got to embarrass him in front of all his colleagues by getting the orthopedics prize in 5th year. And then she concludes, Dad is the epitome of a medical consultant. He acts like he thinks he's brilliant, and sometimes he even tells us that. But we know that he carries a heaviness of guilt, that somehow he sacrificed too much to reach his place of incredible success, that is a professorship. He has sacrificed eating lunch, breakfast, and sometimes even dinner. He sacrificed sleep, fancy holidays, peace of mind, but as his daughter, I can say for sure that he never ever sacrificed his family. He was there at every game, took us to putt-putt on weekends, took us to the Lion Park, i.e. Rondebosch Common, for adventures, attended every single prize giving, ran half marathons with us, took us to church, and made many incredible Sunday lunches. And Stephanie and Dad, you deserve this more than anyone I know. We love and adore you and are so proud to be your children. So it is really my honor to invite Professor Steve Roche to deliver his inaugural lecture.
Professor Lionel, Green Thompson, Professor Liz Langer, and Graham, thanks very much for those kind words and the mentorship and friendship over the last many years, including the cricket games where you were bowling surprisingly well. I was very surprised that a neurosurgeon could bowl so well. To Basil, an old school friend, and he is my older colleague, by the way. Don't look at our hair, you won't know the difference. To my family, and to all of you who come here to honor me here today. I'm hopefully going to show you that collaboration and research has changed the orthopedics research capacity from retrospective case series, which is nothing wrong with retrospective case series, into a diverse translational research group that has improved teaching, research, and ultimately the treatment of our patients by orthopedic surgeons. I turned our iconic leader, Nelson Mandela's quote around, and today, hopefully, I'm going to show you how people have made a difference in my life. In the news in the last 2 weeks, our own Vice-Chancellor, Professor Pucking, and the Vice-Chancellor from the University of Stellenbosch, who used to be our Dean of Medical School, both said that we have to grow the people around us. And at Stellenbosch in 2019, they've been collaborating across the academic disciplines to improve this growth. Today, I'm going to show you how we've been doing this already for the last 10 years. Charles Loyson says, these trees which he plants and under whose shade he will never sit, he loves them for the sake of his children and for his children's children who are to sit beneath the shadow of these spreading boughs. And how appropriate that our symbol is a tree, because we're planting a forest, and I'll show you how we do it through collaboration and research. I'm not going to knock retrospective case series. Professor Teddy Hoffman, a giant of a man and an intellectual, most of his was retrospective case series, because he had to understand how his treatment was affecting people and could he improve it. So there's nothing wrong with retrospective case series. If I take him back to 2003 when I did my fellowship, Abe Lamprecht, one of my other great mentors, actually ran the International Congress of Shoulder and Elbow Society here in Cape Town in 2000 and managed to, from that, to fund the Shoulder and Elbow Fellowship by the South African Shoulder and Elbow Society, named the Don Mackenzie Fellowship. That year, I did a collaboration with Abe and Theo Roche up in Pretoria, and we presented this paper on osteochromiale, which is actually non-fusion of bones in the shoulder, at the closed meeting of the American Shoulder and Elbow Society. And they only accept about 30 papers from the best shoulder and elbow units around the world. So it was a pretty impressive thing. Unfortunately, we didn't write it up. But that year, I also met Theo Roche, who was our president in 2003, and he is the most biomechanically minded orthopedic surgeon I ever met. Professor Johan Walters was biomechanically minded, and he tried to get me to do hip replacements in cows to see how stable they were, but I managed to move away from hips to shoulders and elbows. Theo and I were the first in the world to use Botox injections to try and stop rotator cuff repairs failing, because you've got to keep the tendon still after the surgery. Unfortunately, we couldn't prove that, but it's been subsequently done by other researchers around the world. But Theo is more interested in working in his own biomechanical lab in his backyard where he makes his own products. And this is a part of a shoulder replacement that he made in his own lab at home. And we've been talking over the years about what to do. Shoulder replacements actually work really well. 90% of people who have a shoulder replacement are sleeping again at 6 months. They hadn't slept because they're shoulder pain. And there's three main types. The first on the left is an anatomical shoulder replacement, where we replace the normal head with a metal head. And on the other side, on the scapular side, we put a plastic implant. Or we can put just a hemiarthroplasty, that's half a head, and we leave it, no plastic implant on the scapular side. Or we can do what a reverse shoulder replacement is, which you can see on the far right. And this has overtaken the world in the last 20 years. In fact, a South African designed it, and it was a terrible failure many years, Professor Kessel. And Professor Gramont from France who reinvented it. And now 75% around the world, shoulder replacement put in around the world are reverse shoulder replacement. And if you look closely, that little almost safety pin you see is to mark out the plastic replacement on the glenoid side, and it's loose. That's the problem with these implants. If you look on this side, if you don't put a plastic implant, the bone gets eroded away, and both of these result in pain and loss of range of motion and function. And the reverse solves this problem. Have a look at this patient on the right. He was at my clinic last week. That's his range of motion. A lot of the spinal surgeons and hip surgeons will say it's probably not very good, but that's fantastic. This guy, when he was in his 30s, had a fracture and had a hemiarthroplasty put in on the left-hand side, and he's had very poor function and extreme pain and sepsis. And after 2 operations and the reverse that we put on the right side, that's what he's got. And he said this is the best movement he's had in more than 20 years. So Theo was trying to redesign the shoulder replacement, and we've been talking a lot of times, and eventually I broke down and said, okay, I'll see if I can find somebody at the university who's interested in trying to help us design the reverse shoulder replacement or change the modification. One simple question, and that's the problem when you meet with engineers. You get one, you go with one question, and you get at least 9 other questions, and we'll see some of those coming through now. So in 2013, with funding from NRF and MRC, we started the Orthopedic Biomechanics Lab. Please go and Google Professor Sudesh Subarasu. He is probably one of the most leading researchers at the University South Africa and in the world. He's a phenomenal guy, and I tell you, I don't think he's even 40. Please go and have a look. He is a phenomenal engineer. So we got the lab, and our first student was the postdoctoral fellow from Nigeria, Dr. Wumi Inyang, and so we went back to the basics. Let's design a shoulder replacement for Africa, for Africans. So we've got to look at the anatomy. Is it the same as all the shoulder designs around the world have been on Western and European? So we went to the basics. That's what the engineer said. We started the basics. And Wumi did the study and found that there's actually changes between population groups. There's different sizes and shapes of the head and inclination and angles. And she's got this published and a couple of other papers with us. So during this time, Jonathan Glenday joined us as a master's student, but he upgraded himself to a doctoral student. And he was looking at, with the reverse shoulder replacement, if we change the position, can we improve function by putting the different positions? And then you take it through a range of motion. He did this on a computer modeling system. I won't go into the depths about it. And what did he find? That actually we could change the range of motion. We could change the strength of the muscles, the ones that were still left there, because it's actually designed for patients who don't have rotator cuff muscles, and those are the muscles that move around your shoulder. And he's published this. In fact, he was doing so well, he actually got invited to HSS, which is the Hospital for Special Services in New York, and went to their internationally renowned biomechanics lab and spent 4 months there, and came back and finished his PhD with us. And subsequently, he left us and went back there to carry on a doctoral fellowship and postdoc post there as well. He's published on that work as well. At the same time, Rupam Day came for a master's and he upgraded himself into a doctoral thesis, and he started looking at the anatomy once again, and he showed that even the shapes in the population groups had different what we call peak points. So not only was it not a perfect sphere and all the changes that Wumi had seen, but there were other changes that probably influenced why the cup side or that plastic side was failing. And he published on this work as well. And in fact, what he came up with, that the stresses on this plastic cup on the glenoid side wasn't uniformly distributed. So he came up with the design in his PhD, and guess what? We got another PhD student, Leanne Hayworth, and she's taking these plastic cups, and here she is implanting them into a bone substitute. Then, because she's a PhD, she's got to design the whole instrument to do this testing. And there are some testing jigs around the world, very few, but this is a new one looking at different biomechanics property of this. And then we're going to test Rupam's new idea. And by the end of the year, we'll know whether it was any good or not. But while we're doing this, we started attracting other students. So Seth Thompson looked at the reverse shoulder replacement, and he wanted to see if we moved a tendon around. So some of these shoulders don't have tendons in them, so we can move a tendon to a different position, and you place it in different parts of the part of the humerus, as shown here. And he did this on a computer modeling system and showed that there was a difference where we put that shoulder replacement to improving strength and range of motion. And then we went and validated with the cadaver test. And luckily, we had a biomechanical engineer who's also an orthopedic surgeon and done an upper limb fellowship in a prestigious French university. He came and spent 4 months with us and actually worked on this with us and got that. He's still not published. We're sending emails asking him to publish it, but it will be, and it's been presented around the world. Alexandra has joined us a little bit later, and she's also looking at trying to move the tendons around the shoulder to improve function of the reverse shoulder replacement by moving the tendon around. But which tendon should we move? Should we use this one, which is a bit lower? Should we use a bigger one, the latissimus dorsi? We should use the lower trap. And this is sort of more recent work that's happening around the world, but nobody's tested these three muscles around the world. So it's innovative work, and we'll see what her results are. While she was doing this, I came to her with another question because we had to answer it for the American Academy, that I was an invited speaker. And she looked at the front tendon in the shoulder to see if we, after you cut it during the operation, where we place it back in the shoulder, does it help change the range of motion and strength? And if we use different types of shoulder replacements for the reverse, does it make a difference? Well, it doesn't make a difference. That was the conclusion by Alexandra, and that's the publication really. But we included some of the orthopedic surgeons who looked at the fractures of the scapula, unusual fractures. These plates are designed by one company in the world, and they're designed on Western European scapulars. What did we find? First of all, they didn't fit our scapulars, and then secondly, they didn't address the fractures, which is the most important part. It doesn't matter if they fit to the scapula, but do they actually address the fractures? We carried on with Jaapie de Wet, my present fellow. Is he here? No, he's in trouble. Funding's going. So, and he looked at the different fractures. They're looking at the scapular bodies. Once again, same findings. They don't address the fractures. So now we got the really clever doctoral student, another import from West Africa, Habtamu, who has done amazing work. What he's done is taken the CT scans of all these fractured scapulars, put them together, and he's mapped where these fracture patterns are. And he's done this using statistical shape modeling, which is so far above my head I don't understand. But he's published on it already, and he's shown where these fracture patterns are. We can redesign those plates now, and maybe we can finally make some money out of the orthopedic biomechanics lab, because all we seem to be doing is putting money into it. He's doing some phenomenal work, and by the end of the year, hopefully he'll have his PhD. We also included my previous fellow, Dr. Roche, who I think you must watch out. He's going to be one of the leading upper limb surgeons in the country. He's gone back up north, back to his own university. He looked at our patients who have dislocated shoulders, and then we do an operation on them. And there's a problem, the bone resorbs after the operation. So we looked at vitamin D levels after seeing one of our international cyclists having very soft bone and a low vitamin D. So we started testing all our patients, and what did we find? These are young people, teenagers and over 20s, more, and we found 80% were either insufficient or deficient of vitamin D. Luckily, we didn't show it made any difference to the bone resorption. That's because we replaced them the very week after they had had their operation. So maybe if we didn't, they may would have bigger problems. But he's gone on to join us with a PhD now, and he's looking at the surgeon's planning of the reverse shoulder replacement to see if we can improve outcomes and stop complications, because they have higher complications than the other shoulder replacement. He's presented this already at the SAOA, and in fact his work's so good he came and joined us on the global shoulder arthroplasty meeting. We actually discuss around the world how to do surgical planning for reverse shoulder replacements. We've also been doing a little bit of elbow work, and Sadiq graduated with his master's looking at changing how we fix fractures around the radial head. And because of IP, I'm not going to show the design here. But probably one of the amazing papers that we have is that Sudesh introduced me to Sericam, where they did mathematical models on the tongue to stop snoring. So when we heard about this, we thought, let's take it and see what happens when we put the shoulder replacement into the scapula. What happens to those stresses there to prevent failure, so pull out from the bone, or the stress fractures. And all I know is I gave them the title of the talk and I saw the conclusion, and there's a mathematical model on how the bone works. Anyway, she showed that we can use this model now. This is the way forward. If you adjust the screws, you'll see the change in the stresses on the scapula, and this is going to, hopefully some clever people are going to take this forward, but it's certainly not going to be me. So we've had more than 30 publications and multiple conference presentations around the world from the Orthopedic Biomechanics Lab. And this bridge between upper limb surgery and implant design has led to some important collaborations, and you'll hear about Professor Janine Gray later. We've been involved in mechanical engineering, the orthopedic unit, which research unit you'll hear. We've got collaboration with New York, France, China, and our very own statistical shape modeling experts here in anatomy in the Department of Biology. COVID interrupted some of the research, but we responded, especially Sudesh and the other lab that he's established, the devices lab, and Matthew Trusler designed the UCT visor, which was donated to UCT. Some of it was donated to UCT and Kruder for protection. Here's my son in hard lockdown, pretending how he's helping us design shoulder placements. He's on the left-hand side of your screen. And here I am testing the Ubuntu booth, which is donated to Kruder and with some funding from the orthopedic department with the designer Tertius de Villiers. Let me go back a little bit further to 2012. Professor Dunn's vision statement on his getting the chair of orthopedics was to obtain success, we need to do administration, which I promptly forgot about, and academics and clinical service. So I listened carefully to Rob and Dr. Belinda Jacobs, who looks after the surgical divisions at Kruder posted this report last year, and I looked through it and I saw that I ran the busiest single surgical consultant-led OPD at Kruder Hospital, despite Professor Dunn trying to catch me up, and Professor Solomon saying that he does all the work on the other side, but that's because he's got a couple of extra consultants. At the same time, I identified Michael Held. He did his MEd with me, and we were looking at patient outcome scores. When you want to follow up your patients, you need to score them to see how they well are doing. And subsequent to that, we've managed to publish 2 more outcome scores. But more importantly, Rob and I identified them as maybe taking our way forward in research. We cannot do the research. We're too busy. We needed somebody to coordinate it and run it. And here was the ideal candidate after doing his MEd with me. And this is what he's done, Orthopedic Research Unit. He's grown this fantastic unit and got it accredited by the university, but typical youngsters, they come along with fancy names like Orthoballistics, Good, Muti, SOS, and then he puts our names next to it and says, now we the collaborators and now must work together and produce research. So let's just look at some of those orthopedic ballistics, which is about gunshot wounds. But I'm going to go back to my registrar training, and you'll hear some stories. Gordon Sabota was one of my huge mentors, and we did a huge study looking at more than 100 patients with pelvic fractures. He was a meticulous record keeper. These were his pelvic fractures, and that's how we kept it. There were no computers in those days, so we had to work on papers. This was a massive task. It took me 160 hours on my little computer that we had that said, besides all the paperwork, and I sent it to the journal Bone and Joint Surgery in America, and they turned me down. After all that work, I vowed I'm never publishing another paper. It's not worth it. So I never published again until 2009. It was my first publication. So I abandoned it. And what we published this in 2009 because Gordon sadly passed in his 50s, and this is in memoriam of him. So what he showed that if you gave them anti-inflammatories, we could stop this bone growing across from one side of the hip to the other. It was a phenomenal piece of work, and I really think they missed a beat by publishing. They published a very similar paper 2 years later with the same flaws that they declined our paper. Very upsetting for me. Anyway, let me go on. So he was already showing us, he ran the trauma unit, one of the trauma unit sites, and he did all the pelvic works. Well, we found a very good successor to Gordon, Professor Sitomba Mukungo, and we've had more than 12 publications together. Sitomba will say that probably 11 of them are his, but I'll tell you there's one, a shoulder and elbow with a clavicle fracture, so I can claim one Sitomba out of those. Not only that, we've done a couple of races. Michael also set up the first masters in global surgery, and we produced the one with Esme Engelman. Note it's an upper limb paper as well, with looking at one of the real problems in Cape Town and South Africa, interpersonal violence and gunshots. In 10 months, we had 294 gunshots. And if you look at our OOU and our research stream that Michael put it, we've now got 12 publications from foot all the way up to cervical spine on publications. So if we move on to, my glasses are not with me, sorry. So modifying orthopedic outcomes, you've heard already about our scoring process, and we moved to MUTI. I'm not involved with it at all, but I just will have a brief mention of it. And the host study has brought in more than 5 million rands worth of funding, a PhD researcher from Liverpool, and we have the biggest series of femoral nails and tibial nails looking at HIV infection rates. It's a phenomenal research process, but it's not mine, so I'm not going to talk about it any further. This is Robin Waters, our PhD candidate in the ORU, and she's looking at HIV and TB in spine and other parts of the body. And this has been a phenomenal research group that has involved immunologists, infectious disease clinicians, orthopedic surgeons, and hopefully they're going to produce many papers out of this world-leading research. But she was refashioned also during surgery and published a paper. I managed to sneak my name onto that one as well. And we showed that you could actually operate safely without killing patients during the COVID series, which is actually against what they were publishing in China, where 30% of people who had surgery died from COVID. And by safety protocols instituted by the hospital orthopedic department, we managed to prevent all these deaths. We've spoken about the biomedical engineering lab, as you can see, and then the other research stream was the Blue Sky. And if you know Michael, this is airy-fairy, but it works. My other fellow, Jimmy Kauta, one of the hardest working guys in the country at Mitchell's Plain, he actually has improved the orthopedic healthcare in the community hospitals by a simple WhatsApp referral and advice. So the SHOs, the MOs refer them by WhatsApp and they get immediate advice from this. It's absolutely phenomenal. So we've improved our platform of orthopedic care in the Western Cape. And he's actually managed to publish in the Journal American College of Surgeons. So well done to Jim. But you must remember, he's an upper limb fellow. So how's all this changed the teaching and learning? Well, it's affected all aspects of our training from undergraduate right down to the community. And me start in 2009. You can see I'm starting to get some publications. Mike Mulder, who's now an upper limb surgeon as well, shoulder and elbow, went and looked at what happens with shoulder dislocation. We found actually the understanding of dislocation of the shoulder was diabolical in emergency units around the Western Cape after a survey had been around. Bobby Dax, who was my most prolific fellow and registrar with more than 6 publications with me, looked at a validated questionnaire on undergraduate medical training in orthopedics. And what did we find? 91% of our interns failed a basic orthopedic exam. We repeated this. There was no difference, however, to UK and USA. So we were just as bad as the other countries where this validated question. We then retested them 2 years after internship, and guess what? We didn't improve their training. So we had to do something about this. And the first thing is we got the university to buy in, to give us more time to train. And it was a big fight, but Rob eventually got them to give us some more time. We looked at a student-centered approach, which Michael and the rest of the department bought into and revised the textbook. So we started making student videos. And we got a Delphi process from collaboration throughout the world and locally and in Africa, as well as educationists, not just orthopedic surgeons. And this was the distribution of the people contributing to the book. And it's finally won a prize last year as the best online publication, including as well as Professor Johan Fagan in ENT, as the online book by UCT. Even more proud is that my daughter's actually been able to publish one of the chapters with me, and her boyfriend as well. So if we look at the UC Teach Author online video access, amazing figures. We have more than 1 million views. This was done in March 29 when we looked at it. Look at that, 1 million views. If you look at more than 7, on December the 15th, 2021, we had 7,000 people coming on board. If we look at 41,000 watch hours times, can you imagine how many lecturers or teachers you have to fund to give 41,000 worth of teaching hours? And then if you look at, most importantly, 117 people are coming back to the website on this one day. That's the 15th of February this year, and 600 new people visiting our website. And this is an example of one of the videos that make. It's on patient education. It's also teaching undergraduates, patient education. And if we can see. And what's the amazing thing about this, besides being an upper limb process, is that the incredible, the production is incredible by the students, and obviously they have a lot more understanding how to produce a video than some of us older guys here with less hair. Maritz Loebscher has really transformed our postgraduate training. Used to be Tuesday night lectures, used to be an hour to 2 hours. As you can see, he also did an upper limb paper looking at interposition arthroplasty, really difficult operation for complex problems, showed it worked in about 50%, especially if you have a bottle of whiskey before you do the operation. He's put our training footprint around the world. These are the people who come onto our online meeting, not only in Cape Town, South Africa, but around the world. And here we can see people from around the world and from East London, some of our trainees who've now joined us here in Cape Town. I was very luckily invited to teach the Teacher's Elbow course by Professor Mori, who is Mr. Elbow in the world. And I learned the value of cadaver labs. I brought it back to our department, and gradually we started doing more and more cadaver labs. And the industries realized this, and I'll talk about this just now. We've managed to get 2 ultrasound machines self-funded by the department to train our registrars and to use in the department. It actually stops the patient waiting 3 months for an ultrasound in the radiology department, then come back to us and get a decision about an injection operation. They get the ultrasound on that day and they get the injection. And we started back in 2003, and I now see anesthetics, emergency units, ICUs, and all using it over the last few years. Here's Basil Vretos, probably the most important mentor in my upper limb training. What he does is he trains our registrars on a Wednesday afternoon, and there's one of our registrars at the back. There's the fellow, Dr. Rachueni, and there's a visiting Zimbabwean surgeon. So our private-public teaching process continues. COVID also destroyed our elective surgery. So what we did, we started a Monday shoulder surgery meeting when I coerced some of my shoulder and elbow friends to video their operations. And then we had showed to the registrars around the country, and we had about 100 registrars a weekend. Here's Basil. First time I think he ever saw the nerve. Now they had to explain it to people and how to do this operation. And this is trying to do a biceps repair. Amazing video out of, I think it was a cell phone. So how is our training doing? This is a paper just been published, and actually by Professor Dunsdorf, Cara Dunn as a student. And it actually shows that our orthopedic training for registrars withstands scrutiny, an excellent paper. So we started the fellowship in 2010, Basil and I, basically because we wanted to improve our research, not to improve the skills of the fellows, but to improve our research. However, it does have spin-offs. And that was from a BRI several years ago, and here's a couple of the other guys I've been through. Viciouslavv, one of our registrars, very kindly undertook a a questionnaire evaluating our fellowship, and there were multiple things saying how good our fellowship was, but I won't bore you with. But what he did show, most importantly for me, is 70% of those fellows are now in teaching institutions around the country. Up north, Durban, Mitchells Plain, Paarl, Somerset West, and now Tygerberg shoulder and elbow unit as well. And that's spreading the word of shoulder and elbow around the country. JP was my second fellow, managed to get a bunch of the shoulder surgeons around in Cape Town together and looked at Bangkok shoulder instability operations and showed they don't work in rugby players. Nobody believed in me until we finally did that study. And now he's published several papers on instability surgery, including the first paper on females who have shoulder surgery for instability. And we followed up. In fact, if we go back to there, you'll see there are two names of students. They participated in the student models during their third year. And this paper, we also got two students who published in this paper as well. We're looking at the gender difference between part of the bones in the scapula. We got our second master's graduated, another upper limb fellow, and won the prize at the SAOA. Robbie Dax, my most prolific publisher from the fellowship, probably our most important paper showing that by changing the operation, we have reduced the complications of total elbow replacements in our patients. And it probably is going to change most elbow surgery, I think, around the world now. It's a retrospective case series, though. So not all surgery is bad. But he also published on ulnar nerve. We've got the lowest incidence of ulnar nerve problems following elbow replacements. And we got an international fellow, Anna Foxeloo from Netherlands, who looked at the biggest series of hemophiliac patients undergoing total elbow replacements. We even collaborate with the opposition, Felipe Montoya, as you can see, the anesthetist. And this is Dr. Nordia, my one fellow. You can see showing how we operate in this position in the shoulder. Unfortunately, he still hasn't published. He promised me last night that he's going to. And here's Felipe taking out the frustration of working with me, taking on the anti-vaxxers outside Groote Hospital the year afterwards. We also initiated, I saw patients in a limited private practice that I do that have no funding, the disadvantaged patients. So we discussed this, and Michael Held and Professor Jeroen Swart and Caroline Dalton, we set up the sports orthopedic service and for the disadvantaged patient. Instead of waiting 3 months to clinic, 6 months to MRI, and a year and a half to surgery, now fast track, and they've seen more than 350 patients, disadvantaged sports people from my local communities. I wish I had more time. This research with Janine Gray was another find, like Sudesh, has been phenomenal. We've dragged her away from Cricket South Africa, where she was looking at backs. She started in shoulder pain in cricketers, and I came on at the end, but now we've got two publications ready for water polo players and their shoulders, and we have another 4 research processes with this. And this has led to trying to prevent shoulder injuries, and we've run several events, and we even have a coaching course up now for all the water polo departments around the country. Janine is a physiotherapist, by the way, so we're also doing research with some other physiotherapists, and this has just been published on return to play following musculoskeletal injuries, and she's got an Adelphi process that's carrying on doing our PhD, Greta Geldernaes. I had very difficult shoulder and elbow problems that I started taking to a few local guys asking for advice back in 2004, and this has grown, and we have a vibrant working group. We have monthly meetings now with an average of 14 shoulder and elbow surgeons meeting for about 2.5 hours. We have more than 361 patients presented at the meeting. That means they're getting improved care of their shoulder and elbow problem, and that was just from July 2017 to 2020. COVID time made us get online, and here in East London, enjoying some Western Cape wine. Abe, unfortunately, had to get his daughter to work for the Zoom. He wasn't able to speak to us, and we got people joining from Durban. And as you can see, most of us are enjoying the meeting, except for Jimmy. I think he was working too hard at Mitchell's Plain. One of my other fellows has moved over to Tygerberg. He's managed to do some international research with our Australian colleagues. Both have been presented over there and back here, also waiting for the papers to be published. But probably the biggest mentorship, as I said earlier, has been Basil Freitas. Not only was he at school with me, but he brought back the whole and started the upper limb unit here in Cape Town. So Basil did a fellowship with 2 famous surgeons, Professor Angus Wallace, who very famously put a wire in somebody's chest on an airplane because they had a pneumothorax, and Lars Newman, an elbow surgeon. And here was Professor Andy Carr from Oxford University looking at an elephant shoulder. Basil dragged me along to Harare knee and shoulder arthroscopy. So all our cadaver courses have been recognized by the community, and here we are being invited now to teach the surgeons from the rest of Africa on how to do shoulder and knee surgery up in Harare. And this has been subverted by COVID, but we managed to do. Basil's here in Rwanda presenting all our academic papers. And this industry, seeing how well our cadaver courses have been has introduced, has allowed me to run these cadaver courses with them for the other universities graduates, because many of them are not exposed to shoulder arthroscopy. And we have more than 100 young orthopedic surgeons around the country that we've taught. We also teach the older orthopedic surgeons. We have 100 people coming to the hard shoulder course. We have some invited courses, and I've been running that for the last couple of years. But we do collaborate with other people, the hand units. We've done some amazing work on brachial plexus injuries in the young children, and even pediatric guys, Stewie Dixbeek and I, when we were back as students, looking at some biomechanics and unstable pelvic fractures. Not only are we changing the face of our research, but if you look back here, this was several years ago, the faces are changing, the sports are changing, we're having fun as a department, but we don't only have fun out on the sports field and soccer fields, we have some fun in surgery. Last year I was invited to be one of the 15 surgeons around the world to introduce mixed reality surgery to the world. We put together a team, as most of us don't work in the silos, and you need an orthopedic team. Here are nursing staff, fellows, registrars, scrub stitches, and anesthetic staff, making this an incredible first for UCT in South Africa. I've been lucky enough to do 5 continents and 20 major cities as a speaker and presenting our international research. So orthopedics and shoulder and elbow surgery is growing in Africa through collaborative and translational research, with innovative teaching, vibrant group of orthopedic surgeons, South Africa providing mentorship and fellowship, and I think socially responsible. These are all the people that we're collaborating and researching, not just our patients and retrospective research. And I'd like to thank my colleagues and for the fellowship and mentorship, to the undergraduates, registrars, and fellows who've contributed to my privilege, to all the anesthetists, nursing, and other support staff who put me up with me, and to the amazing young researchers who allowed me to be part of the research groups, especially Sudesh and Janine. Thank you to Kurdiske Hospital and Dr. Bhavna Patel and UCT for allowing me to work in this privileged environment. And lastly, to Professor Dunn, not only dragging me through 2 comrades up and down, but dragging him through his vision of improving the care of the orthopedic patient in South Africa. And finally, thank you to my family.
A truly classic inaugural lecture, and I hope we'll see more of the same as we go through them. But I had hoped that at an orthopedic delivery we would get away without a snide anesthetic remark, though. But I was living in hope. Congratulations, Steve Roche, on an excellent delivery of an inaugural lecture, and to the Division of Orthopedics, who have clearly contributed to the work that we've seen here this evening. But I think my one reflection as I invite Basil Fritos to deliver the vote of thanks is really just a reflection on the extent to which our success happens at the intersection of people and the places we work and the promises that we make to ensure that the world is better after we've been here. I invite Associate Professor Basil Fritos to do the vote of thanks. After that, Liz Langer will say a few words, and then I invite you to some refreshments after that.
DVC Liz Langer and Prof. Arnold Green-Thompson and Graham Fagan, thanks very much for inviting me. I was sort of a little bit late, just 2 days ago, when I mentioned, do you want me to say something, when you asked me for some tidbits on Steve? And then I didn't realize the next day, day before yesterday, he said, hey Basil, actually, would you like to come and talk? So it was a little bit of a shock, but anyway, something that Steve often does to me. But really, this is a great honor, a privilege, and a pleasure to give the vote of thanks to Steve. I mean, Steve and I have been connected for many years. We worked together for 20 years, at least 20 years now. And the one thing Steve always says, you know, we have never had a fight. And it is actually quite amazing, because surgeons do not get on with each other all the time. we have this thing that we talk to each other a lot, maybe a bit less than we used to. And my wife and I think Mareka both said it, you talk to Steve more than you talk to me. So our relationship goes very far. But certainly I've learned far more from Steve than he's learned from me. There's no doubt. And you can attest to me to that is what you've seen today. And I don't think there are many people who have achieved and have done so many things that Steve has done. And it's such a credit to this university. We actually did go to school together. And when I tell people that, they say to me, but, hang on, how many years above you was Steve at school? So I say, oh, yeah, no, he was many years above me. I was quite a junior, but in fact, he was 3 years below me. One thing about Steve is extremely humble. And it's one thing that you probably don't know. And this meeting he talked about, you can imagine a group of surgeons getting together and talking, and they don't want to show their problems. And those surgeons are often in competition with each other. So it gives a very difficult environment. But Steve started that meeting, and he would present all his problems, all his complications, and with a bit of humor as well. And I have to say that he does have some successful operations. But that meeting produced an environment where the younger surgeons coming to the meeting suddenly thought, well, these guys are showing all their disasters, and hopefully we don't have too many, and they would start presenting their cases, and they didn't feel threatened. And it's amazing how that group of surgeons has gelled, and we have this meeting carries on today, and it's a highlight of our week. Surgeons from other parts of the country have joined the meeting, and they often say, we could never do this in our province. The guys would just fight with each other, or they don't talk to each other anyway. So it's engendered a true fellowship between a group of people, and that's really thanks to Steve and his humility. And that humility has led to him being held in extremely high esteem by all these colleagues. We've seen that he's extremely passionate about teaching and his academia, and he is so well read. I mean, I don't know anyone who knows more about his subject and general orthopedics, and not just general orthopedics, but anything about all medical things than Steve. And many of us just, we just have to convince people that we know what we're talking about, but Steve actually knows it. And you see it that we have these visitors coming, and they often say, I don't know, how does he know so much? I don't know how Steve reads so much and does all the work that he does. But there has been a spooner for me because he often tells me what he's read. And so I will tell the guys, oh yeah, there's this paper on this. And then they think I know everything. In fact, I don't, and I know nothing. But he's got extremely high integrity, and you can see that in the manner. I mean, he's academic, he research, teaching, but it's how he treats his patients. And he treats his patients with amazing compassion and care. And that's irrespective of who they are. And in fact, it's almost to his detriment because he's available to his patients all the time. I mean, the one time I think he was on holiday on the beach in Kenya, and I keep getting SMSs, or WhatsApps. Can you see this patient? So patients, he's even answering his patients. I said, Steve, switch off your phone. But his dedication to his patients is unsurpassed. There's not many doctors, particularly surgeons, who would do that. The Greeks have 5 words. I'm Greek. So there are 5 words for love. And one of which is philia, which means deep friendship and understanding. And certainly I have that with Steve, but Steve has this relationship with so many people, not only in his working life, but in his personal life. When someone's sick, Steve is there. He's just amazing. So I don't know how he fits all that in. But I just have to say thanks to Steve for an amazing presentation. I mean, really, and just all the work you've done and the contribution you've made to this institution, and in fact to our medical society in South Africa as a whole. And also for being a great philo, male of philia, to so many of us. Thank you.
Good evening, all. You were complaining that you were told that you needed to speak 2 days ago. I was told here in the queue. So it's completely unprepared. But I would like to bring the university perspective in terms of what an inaugural lecture is. Universities are very old institutions, and rituals, rites, are very much part of the culture that keeps together these organizations that keep on changing from century to century and yet in some respects remaining the same. And for me, each inaugural lecture is an act of renewal. It's a rite of renewal of what the university is. It is the notion of the community of students and scholars that gets transmitted, and it's each new professor that achieves this height is somebody who's shining the light on the others and is passing on to the others. So to all of you, professors and non-professors, and specifically to Professor Roche, thank you for your contribution for this university to keep on being a university. So thank you very much, all of you, for coming and being part of this important rite of renewal for all of us. Thank you.